I would request Dr. Garvita Singh to present her paper. She's there. Dr. Niranjan, yeah, you can start your presentation. Yeah, yeah, sir.
Ma'am, how much time do I have, ma'am? 6 minutes. Good afternoon, respected judges and one and all. So I'll be presenting my paper on the topic an analytical study comparing the slit lamp exophthalmometry, a novel method, with hurdles and CT imaging in quantification of axial proptosis. So aims and objective was to analyze and compare the accuracy and the precision of measurement of proptosis in cases of axial proptosis using a novel slit lamp method, and to compare it with the gold standard methods of hurdles and CT based methods. So the inclusion criteria was more than 18 years with unilateral or bilateral axial proptosis, and patients with a proptosis difference of more than 2 millimeters between two eyes, and those with eccentric proptosis and traumatic fractures were excluded from the study. So this was the novel method of slit lamp exophthalmometry, where initially the apex of the cornea is focused as shown in figure A, and the initial arc is marked from the base of the slit lamp, following which the lateral orbital rim is localized with the help of a tip of a pin, and the second arc is drawn, and the difference between the two can be measured using the counting the number of small boxes between the two arcs as drawn here in figure D. So that is compared with the gold standard of Hertel's exophthalmometry as shown here. And we also have three ways of measuring proptosis using CT scan. And the first method is where there's a horizontal line between the two orbital rims. The second method is pertaining to unilateral cases. And the third method is from the sagittal section. So following which statistical analysis was done, and interclass correlation coefficient was chosen as a method of understanding the reliability, and Bland-Allman plot was plotted to understand the correlation of different values. So these are the demographic details of my study, where 46% of them were males and 54 of them were females. And let's move on to the results proper, where there is a comparison between the slit lamp and the hurdles, which showed a significance of p-value of less than 0.01, which is statistically significant. And this is between slit lamp and hurdles, where the Bland-Allman plot showed that the most of the values were between minus 1.96 standard deviation, which is of significance. And following which the slit lamp exophthalmometry was covered with compared with three different methods of CT, which is shown in the method 1, where the lateral orbital rims were the parameters, and here again it was proved out to be statistically significant. And this was the Bland-Allman's plot, which again showed a correlation between that of slit lamp and the method 1. And this is with the method 2, which is pertaining to unilateral cases between the medial and the lateral orbital margin, and that of slit lamp, which was showing statistical significance as well. And here is the Bland-Allman plot, which was also showing the standard deviation to be less than 2 standard deviations. And same goes with method 3. So all the three methods and the comparison with the hurdles were showing statistical significance. So here is the graph of the same. So moving on to discussion, slit lamp exophthalmometry is actually a very simple and objective method which can be done in any of our outpatient departments. So having a method which is showing such a good correlation with that of the gold standard Hertel's exophthalmometry of 0.958, which actually shows that an ICC of more than 0.9 itself is supposed to be having a very good, or in fact an excellent correlational reliability. So that was one finding in our study. And the three methods, all of them showed to be more than 0.9 as well. This again was a point in favor of saying that using the slit lamp method can go a long way in sort of avoiding repeated CT scans, especially during follow-up. And one specific feature which we noted was that the CT method 1 correlated well, whereas the study by Park et al., where it compared the CT and the hurdles, showed method 2 to be more correlative. But that was because the slit lamp method was more similar to the step 1 compared to Park et al., which was more similar to the step 2 or the type 2. So I would like to conclude by saying that Hertel's is a very commonly used method, and method of using slit lamp, which has quite good correlation with that, can prove to be a very good and a useful substitute for measuring proptosis in axial proptosis. Thank you. Yes, ma'am. It was done by the same person, principal investigator, which was myself, and in using the same slit lamp, ma'am. No, ma'am. It was pretty much restricted to axial proptosis itself. Yes, ma'am. Yes, sir. Actually, there was one study done in Japan, which was done with only 60 eyes, but I have done it with 80 eyes, and there they have compared it only with the Hertel's, but I have compared it with CT methods as well in a single study, sir. Yes, sir. The model of the slit lamp was same, but the company was different, sir. Ma'am, in fact, this was much quicker because the measurement was already like you just keep a slit lamp, the graph paper already set. So the patient just has to sit, measure. It took less than 10 seconds for me to finish this, compared to the Hertel's, where we had to like get the Hertel's and positioning it in the lateral rim and measuring the baseline and then going for this was a tougher job. So it was much more quicker for me.
Good afternoon. Should I start? We are talking about the role of afferent pathway in blepharospasm and blepharospasm with dry eye. I have no financial interest and photos and videos used with consent. So blepharospasm as such is the involuntary contraction of the protractors of the eyelids. Conventionally, it's divided into two types: the benign essential blepharospasm, which has a central mechanism, and the reflex blepharospasm, secondary to dry eye or ocular surface issues. And the way to differentiate the two is often quoted as, if you put a drop of topical anesthetic in the eye, if the spasm improves, it's a secondary blepharospasm. However, studies also show that there are certain external stimuli which are known to trigger spasm in BEB, such as flickering lights, going outdoors, and so on. And there has been one study which rather counterintuitively shows decreased corneal sensitivity in BEB. On the other hand, we have a set of patients who have definitely clinically proven dry eye, including staining, Schirmer's, slit lamp examination, and they complain about not being able to keep their eyes open even with the maximum medical treatment. So now we have a dilemma, two sets of patients. These patients, we are afraid that if we are going to put botulinum toxin chemodenervation around these eyes, they'll probably end up with further dry eye and further lag ophthalmos, which will make things worse. So the question is, does the afferent corneal pathway have a role to play in blepharospasm as well as blepharospasm in dry eye? So this is a prospective observational study, January 2020 to June 2021. Consecutive patients presenting with blepharospasm were assessed at oculoplasty and the cornea services at Narayana Nethralaya, and the control group was a consecutive patients of dry eye seen by the cornea services. The dry eye was treated with optimum management, and if persistent blepharospasm was there, they were referred back to the oculoplasty service. Aesthesiometry was done for blepharospasm patients, confocal microscopy was done to study the subbasal nerve plexus. Schirmer's test and ocular surface discomfort index was checked in all patients. A single evaluator looked at the blepharospasm, graded it by Yankovic grading, and injected incobotulinum toxin type A in a pattern that is determined by the inspection of the most forcefully contracting muscles. And the patient was reviewed at 3 weeks and to confirm that that was the correct pattern and dose, and followed up when the spasm recurred. And post-injection tear substitutes were continued. So as an example, this is a picture of a normal nerve plexus, where you see these 3 pictures are all from dry eye patients where the long nerve fibers are fewer, they're broken up into short bits, there are lots of dendritic cells, and the ends of the nerve fibers are swollen, causing microneuroma. Microneuroma is a formation that is known to be significant in neuropathic corneal pain. So ultimately, we had 86 eyes of 43 patients in 3 groups, with essential blepharospasm group A, group B combined dry eye and blepharospasm, group 3 dry eye with no blepharospasm. Group A and B, the 2 types of blepharospasm, had similar mean scoring, similar optimum dose of chemodenervation, and similar mean number of months of duration. There was distorted subbasal neural plexus seen in 27% of group A and B. Corneal sensitivity in both group A and B was decreased to 35 millimeters, where the Indian normative data talks about 54 to 58 millimeters. Microneuromas were more in group A compared to group B. Microneuromas were more in the blepharospasm group compared to the pure dry eye group. Ocular surface disorder index discomfort index was less in group A, but combined A and B were again less than group C. So afferent pathway abnormality was associated with BEB and dry eye associated blepharospasm. Now, this is an association. We cannot say that the afferent pathway caused the blepharospasm or whether the frequent forceful blinking of the eyelids caused a damage to the corneal epithelium. So blepharospasm with dry eye, however, is distinct from isolated dry eye, and it is also distinct from BEB. So it is okay to put the chemodenervation for blepharospasm associated dry eye, but tear substitutes have to be used in all essential blepharospasm, and probably in future one can look at the pain pathways also for the control of the blepharospasm. Thank you. Blepharospasm. This is Yankovic grade 3 and 4. This is almost non-functional people. They're not able to carry on their normal activities without the botulinum toxin.
How frequently was it injected?
So the mean gap was about 4 months. That was the mean gap. Thank you.
Good afternoon, everyone. Thank you, AIOS, for giving me this opportunity. Talking about the eyelid reconstruction surgeries, our main goal is to achieve adequate globe coverage, proper lid closure, preservation of tear film integrity, and aesthetically appealing eyes. So, common indication of lid reconstruction is post-trauma, post-tumor excision, acquired coloboma, post-burn, post-trauma, and congenital coloboma. So aim of our study was to review indication, surgical technique, outcome after eyelid reconstruction surgeries. It was a retrospective interventional non-comparative study including 25 patients who presented from 2018 to 21 and had follow-up of more than 3 months. Those who had follow-up of less than 3 months or lost the follow-up were excluded. So here are our results. Mean age of presentation was 47 year with male preponderance, and post-tumor excision coloboma was the most common cause of the clinical diagnosis. Upper lid full thickness, right eye central defect was the most common presentation. Most patient had lid defect of around 50% or more than that. The surgeries that we performed were direct closure, tensile flap, Hughes flap, Cutler Baird procedure, and Frick's procedure. Mean duration of follow-up was 18 months. At a mean follow-up 18 months, most patients had good lid contour, well-formed lid margin, and adequate lid movement. Here are some of our cases. This one was a patient of upper lid hypertrophic nevus. Pentagon resection was done, followed by direct lid closure, and this is post-op picture after 3 months. This patient had lower lid sebaceous cell carcinoma. Post-resection, there was more than 50% lid defect, followed by tensile flap reconstruction. This is post-op 1 week picture, and we can clearly see a well-formed lid margin here. This is another case of post-tumor resection, lid coloboma, followed by tensile reconstruction. This is post-op 12-month picture. A very well-formed lid contour can be seen here. This patient also underwent post-tumor.
Pause the presentation. There's something wrong. The display is gone off. Can someone call someone from AV, please? I think there are 3 minutes left for your presentation. We'll just hold on.
Yes.
It was saying for quite some time that it needed a key to be pressed. Yeah, it's visible now. Giving you 3 minutes starting now. Start, please.
Thank you, sir. This was also post-tumor resection. Here we can see more than 50% of the lid coloboma. A Hughes flap was raised to create the posterior lamina. Tarsoconjunctival advancement flap and anterior lamina was reconstructed by advancement of musculocutaneous flap. This was a case of 45-year male who presented with right eye upper lid large sebaceous cell carcinoma. As we can see, post-tumor resection, there is more than 75% of lid defect. Cutler Baird surgery was planned for the patient, and here in the third image we can see post-operatively full thickness flap in situ. This is post-op 18-month picture. A well-formed lid margin, lid contour can be seen here, except for the loss of lashes. Patient had good lid function. This patient also underwent post-op Cutler Baird, post-op 18 months after tumor resection. This was a case of road traffic accident presented to us with extensive chemosis, loss of upper lid with tissue defect. After settling down the inflammation, primary lid repair was done, and post-operatively a full upper lid full thickness defect with lag ophthalmos was observed. Patient underwent Cutler Baird surgery, and in the fourth image we can see status post Cutler Baird 2, a well-formed lid crease and adequate lid closure was achieved. This was a 62-year-old female patient presented with left eye lower lid sebaceous cell carcinoma involving punctum. A combined approach of bilobe flap with tensile flap was planned for this patient. Here in the third image we can see post intraoperatively both the flaps, and this is immediate post-operative picture. This is post-op 12 month. A shallow notch was there in the lid, lower lid. This patient was full thickness. Patient had full thickness lower lid defect post-trauma. Posterior lamina was recreated by Hughes flap, and anterior by the full thickness skin graft harvested from retroauricular area. This was a patient, 70-year-old male with invasive basal cell carcinoma. After tumor excision, there was 100% lower lid coloboma and upper lid 25% defect was there. Frick's flap was raised to reconstruct lower lid. At 2-week partial graft necrosis medially was observed. The extra tissue from the bridge of the flap was used to replace the necrosed tissue. This is post-op 6-month picture. After that, patient lost the follow-up. So it was a retrospective study of 25 patients. Most common cause of the reconstruction was post-tumor resection, and upper lid was most commonly involved. Tensile flap was the most common surgery, followed by Cutler Baird. Ptosis, lag ophthalmos, partial graft necrosis, and the notch were seen as the post-op complication and managed accordingly. After comparing the literature, it was our observation that in Indian setups, a population-based study has not been conducted that can discuss with the post-operative outcome and complication of lid reconstruction. So concluding my presentation, a careful assessment of defect involving site size and lamella is involved when both the laminas are to be reconstructed. We need a vascularized flap. Functional improvement, best cost basis, and the method convenient to surgeon should be the procedure of choice. Limitation of this study was that it was a short sample study, and being an oncology specialty unit, most cases were of post-tumor excision acquired coloboma leading to selection bias.
sort of studies which showcase what type of lid tumors and which type of lid surgeries are required have been published from different parts of the world.
Yes, sir.
What's the take-home message from your particular study?
So that's what I mentioned in one of the slides, that in our Indian setup, we don't have a population-based study that can gather a large number of patients and discuss about the post-op outcomes and complications associated with lid reconstruction surgery. So it would be better if, like, with more number of sample size, we continue this thing.
Required any surgery for ptosis and
No, ma'am. The lagophthalmus was mild. The notch was shallow. For that partial graft necrosis, we reconstructed that needle from the extra tissue of the flap, fixed flap. Thank you.
Dr. Rolika Bansal, please.
Good evening, everyone. So I'll be talking on adjuvant plaque brachytherapy helping in local tumor control in conjunctival melanoma. So conjunctival melanoma happens to be a rare lethal malignancy with a very low incidence but a very high local recurrence, that is 38 to 52% by 10 years, and it metastasizes, and melanoma related mortality at 10 years happens to be 13 to 38%, quite a high number of local recurrence and mortality. Till now, the various modalities that have been followed for conjunctival melanoma happen to be surgical excision with or without cryotherapy, adjuvant radiotherapy, enucleation, exentration, and even genetics guided targeted therapy. It has been stated in the largest study that has been done on conjunctival melanoma that local recurrence happens to be 19.1%. Quite a high number. We needed to work on it. So what we thought of was that let's think about eliminating the concept of enucleation, exentration, and what if we can help with just the radiotherapy component with a very good and wide surgical excision. So primary plaque brachytherapy is when the clinical examination and imaging advocates the need of brachytherapy intraoperatively, or we go ahead with histopathology proven secondary plaque brachytherapy. And we aimed at assessing that the high rate of local recurrence is related to high rate of metastasis. So we know about it and we wanted to work on it. We conducted a retrospective interventional study on 15 patients of conjunctival melanoma, and we followed the multimodal management, wherein we saw a spectrum of our cases that had dark pigmented flat lesions or an elevated lesion, a prominent feeder vessel, and intrinsic vascularity. Scleral fixity was present in our cases. Corneal involvement, it was important for us to note the involved clock hours, because that that's how we proceed with placing the plaque. Ultrasound biomicroscopy confirmed the evidence of scleral invasion, and the ASOCT indeed helped. Histopathologically, like when we were thinking of secondary plaque brachytherapy, the lesion has pigmented lesion with a full thickness involvement was present, spindle to epithelioid atypical cells were present, and the pigmented lesion had the base involvement. So here we are presenting the most difficult case out of all of these. That was a 65-year-old case who had come after several 2 excision biopsy. He had extensive recurrence and it was a diffuse lesion. And what we saw was that and also there was lateral rectus involvement. So we went ahead with clinically clear margins and we excised the lesion completely. After hooking the lateral rectus, the excised component was taken off. It's as per the MRI that we had done. And the lesion was excised completely by lamellar sclerectomy. The residual components that were left off were also excised to ensure complete excision. And followed which lateral rectus was reinserted, and then we went ahead with placing the plaque. Plaque rotation was important in this and required, and this was as per the dosimetry for 2 mm of depth. After placing the plaque and removing as per the calculated dose duration, we went ahead with considering edge cryotherapy for the residual tumor, And then for the base, as we have said, plaque brachytherapy was done. And cryo was also done to the base. Surface reconstruction was done with AMG, and placing the symblepharon ring, considering the extent, we went ahead with suturataciraphy. And this is the outcome after 8 years, and the patient does not have any sort of metastasis. So we had seen a spectrum of patients ranging from 8 years to 65 years. Most of the cases had the primary lesion as acquired melanosis. The tumor diameter was variable 4 to 17 mm. The tumor height was 2.92 plus minus 1.2 mm. And plaque brachytherapy was either notch or round depending on muscle involvement for hooking it. Dosage was kept as 10,000 centigrade at apex dose. Depth of radiation was 2 to 3 mm depending on the height, and the dose range was 11.5 to 74 hours. These are the outcomes that we had seen, and these are excellent local tumor control after a post-operative duration of 4 years. And according to the AJCC staging, even though all our maximum cases were in the CT3A component, we had local tumor control, vision salvage, globe salvage, and life salvage in all our cases, till a mean follow-up of 8.1 years. Earlier, plaque brachytherapy has been attempted, but it has been variable strontium, iodine, and depending on their cases and availability has been used. In our study, we used ruthenium for all the cases. There was local recurrence in the previous studies, however, we did not observe it at the mean follow-up of 8.1 years. And we are yet to hope for a complete control for 10 years, but we have seen that studies have stated 10 years survival rate of 76.3 and recurrence of 36.9. So what we state is that a good multimodal management where excision is completely done, where residual tumor at the edge and the base is taken care of with cryotherapy and plaque brachytherapy, with the histopathological confirmation, we can achieve excellent tumor control by a multimodal management with a vision salvage, globe salvage, and life salvage of 100% if we try. Definitely the limitation of our study is that it is for 8.1 years mean follow-up. We are hoping to carry it forward till 10 years, and we'll keep you updated. Thank you.
Very nice presentation.
I have one question, Rohika. A great presentation, but I had one question. Now, every center in the country may not have a plaque, right? And if you ended up practicing in a place which does not have ruthenium available, how would that change your management in that multimodal management slide that you showed? What would you do then?
Right, sir. So first of all, you're right that plaque is not available everywhere because it was a limitation to bring it from international boundaries. But it has been made available by BARC as Make in India plaque now, and we're hoping that more and more centers get affiliation. But if that happens, if at all we do not have the plaque availability, then we have to look at cryotherapy as our first approach that would take care of the margin control and even the base. And if the tumor is extensive, if we know as the basis of UBM and ASOCT that it is quite the invasion is present, I don't think it should be something that we should take risk with. Then the concept of enucleation, as even stated by Shields, should be taken up.
So you're saying that if the plaque wasn't present, then despite the other factors of multimodal management which you might follow, a significant portion of these might go for enucleation, especially with the ones which have had scleral as well as corneal involvement.
Right, I do agree, but also Shields have recently stated that even genetics related immunotherapy has been used. There's a spectrum of immunotherapy that is being used. Pebulimab is being currently used to take care of metastasis in these cases.
Thank you.
Thank you.
Were there any other intraocular complications like intraocular pressure or cataract formation or something like that?
No,
you
sir.
said the vision was okay, but what were
Yes.
the other complications along with that?
So in our patients, we did not see any of these cases. One patient did develop cataract, which was taken care of with the cataract surgery, but that was not a vision drop. It was just like an initial cataract phase, but the patient was uncomfortable, so we went ahead. But that was not like a complete effect on the overall outcome. There was no difference, no drop in more than one line in any of the patients.
Okay.
Thank you, sir.
Should we call the next person?
Yeah.
Yes, sir.
Dr. Fazil Khurram, please.
So I will be talking on topic giant sebaceous cell carcinoma of lid, metastasizing masquerading as a diabetic foot ulcer. So sebaceous cell carcinoma, as we all know, is the most common tumor in India. It's great masquerader and it looks like a chalazion. Common sites are metastases are lymph node and liver. Early diagnosis help in the treatment and better survival rate. So our case was a 90-year-old male who was known diabetic for 2 years with a history of irregular treatment on diabetes. His chief complaint was left eye upper lid swelling, sudden increase in the left eye swelling for past 3 months, which was associated with diminution of vision in the left eye due to unable opening of the left eye. It was associated with mucopollulant discharge, swelling which bled on touch, and pain in the left upper eyelid. Past history, the left upper eyelid swelling was noticed 8 months ago, which was increasing in size, painless in nature, and for past 3 months showed a sudden increase in size. The patient also had a non-healing toe ulcer over the right toe. It was small in size initially, which gradually increased in size and was not responding to local antibiotic treatment. And it was diagnosed as a diabetic foot by the local doctor. General examination showed pallor, clubbing, and large left-sided periauricular lymph node, level 1 to cervical lymphadenopathy, an oval-shaped ulcer with serous discharge of 4.5 into 5 into 1 centimeter was present over the right big toe. Ocular examination showed a swelling covering the left eyelid extending 0.5 centimeter below the left eyebrow. Loss of eyelashes, distortion of eyelid margin, hyperpigmentation was seen over the left eyelid surface. On palpation, heart induration fixed mass of above dimension was noted. These are the pictures of the lesions. Here you can also see the toe. So a blood investigation showed that the patient had an anemia, but the fasting and postprandial blood glucose level were normal. He was also HbS-Ag positive. FNAC from periauricular and cervical lymph node was taken, which showed a round to polygonal tumor cell with multivacuolated cytoplasm with nuclear pleomorphism suggestive of metastasis of sebaceous cell carcinoma in periauricular and lymph node. On contrast in CT, there was ulcerative proliferative soft tissue in the orbit involving the lid and extension into the eyeball and left lacrimal gland. Lungs and parenchyma and the right iliac bone also showed metastasis. On histopathological examination, the left eye showed a nest of round to oval bacillite tumor cell showing peripheral palisade with abundant pale vacuolated cytoplasm. The right toe ulcer FNAC showed a non-healing right toe ulcer with stratified squamous epithelium with hyperkeratosis with subepithelium showing nest of tumor cell infiltrated into nearby stroma suggestive of metastasis of sebaceous cell carcinoma. So a diagnosis of left eye sebaceous cell carcinoma with TNM staging of T4N1 M1 with type 2 diabetes mellitus and HbS-Ag positive was made. Treatment, the patient was given a radiotherapy with external beam radiotherapy of 30 grays in 10 divided fraction. A chemotherapy with carboplatin and paclitaxel with 4-5 cycle was given 21 days apart. On follow-up, the plain bleeding and size of left eye swelling and toe ulcer were reduced and the patient was symptomatically better. So to conclude, that it is eminent for the clinician from various departments to be aware of the masquerading ability of sebaceous cell carcinoma of the eyelid and its potential for distant metastasis to rear side with previous clinical presentation, which often leads to misdiagnosis. Poor evaluation and multi-department conclusion with timely invasive investigation procedure for potential distant sites. In all of the literature study, none of them have reported a metastasis of ocular sebaceous cell carcinoma to the extremities like the toe. So it should be taken as one of the clinical features. These are my references. Thank you.
Yeah, it was a good presentation of a single case study, and I think the outcome was quite good to that extent. Yeah, good.
Thank you.
The next paper is by Dr. Anita Venugopal, a novel synthetic material to prevent symblepharon and chemical injury.
Thank you, sir. Good evening, everyone. My paper is on a novel synthetic material to prevent simpliferon in chemical injuries. Simpliferon is a pathological condition wherein bulbar and palpebral conjunctiva form an abnormal addition to one another. It occurs secondary to chemical injuries, drug reaction, SJS and ocular surface procedures. It is easier to prevent than to treat. Many modalities are available to prevent simpliferon, but the pathogenesis of wound healing of conjunctiva and tenons is unpredictable. Hence, the prevention of recurrence is still challenging. In the study, we aim to evaluate the clinical outcomes of Gore-Tex as an adjuvant in preventing the recurrence of simpliferon in chemical injuries. It was a retrospective review of 11 eyes of 10 patients between 2011 and 2019 with a maximum follow-up of 12 months. All chronic cases of chemical injuries presenting with a moderate to severe simpliferon with extraocular motility restriction were included. The procedure was performed under general anesthesia for patients under 20 years of age and peribulbar anesthesia for the rest of the patients. Simpliferon with moderate grade of involving the less than 180 degree of the ocular surface was treated with simpliferon release with Gore-Tex amniotic membrane graft, living related conjunctival allograft or autograft. Patients with severe grade of simpliferon involving more than 180 degree of the ocular surface underwent simpliferon release with Gore-Tex amniotic membrane graft, and simple limbal epithelial cell transplant was done. Post-operatively, after 4th week, Gore-Tex was removed, and follow-up evaluation was done at 1 week, 2 weeks, 1 month, 3 months and 6 months, and 4th monthly until 1 year. Post-operative treatment for given was the antibiotic steroids for 2 months in tapering doses, oral steroids for 2 weeks, doxycycline and vitamin C for 2 weeks. Success was defined as an epithelial ocular surface without conjunctival or corneal recurrence of simpliferon at 12 months. Partial success, epithelialization of ocular surface with mild conjunctival recurrence at 12 months, and persistent inflammation or severe recurrence of fornacial shortening was defined as failure. 11 eyes of 10 patients were included with a median age of 17 years and median follow-up of 36 months, and the median time interval between the onset of the symptom and the first presentation was 9 months. We included 6 eyes of severe simpliferon and 5 eyes with moderate simpliferon with corresponding areas of limbal stem cell deficiency. Along with the simpliferon release, Gore-Tex amniotic membrane graft and conjunctival allograft, 2 patients underwent living related conjunctival allograft, 3 patients conjunctival autograft, and 6 patients SLED. The mean duration of epithelialization was 5.27 weeks and mean duration of recurrence was 6.75. In all our patients, the best corrected visual acuity improved statistically significantly improved post-operatively, and the surgical outcomes include we had 54.5% of success rate and 36.3% of partial success, and one patient like 9% of having failure. Among the patients with moderate grade simpliferon, all patients had success, and among patients with less than 180 degree, more than 180 degree, with severe cases, we had only 16% of the patients with success rate, and 66% partial success was observed with mild conjunctival recurrence. And complications, we did not have any sight-threatening complications, and we had 4 cases of pyogenic granuloma, and spontaneous extrusion of Gore-Tex was noted in 2 eyes before 4 weeks, and recurrence was noted in 4 eyes, and 2 eyes underwent repeat procedure. Fungal infection was noted in 1 eye, but the underlying ocular surface was free of infection. These are few cases in which the Gore-Tex and CLAG was done. Gore-Tex is left in place for 3 to 4 weeks of proliferative phase of conjunctival wound healing. So hence it reduces the exaggeration of fibroplasia and angiogenesis, and thereby prevents the recurrence. It acts as a spacer or the mechanical barrier, preventing the fibrous regrowth and adhesion of the adjacent tissues. Our patients had severe LSCD, with all were young patients, and they were associated with severe fibroblastic response. Amniotic membrane, it promoted epithelialization, and the conjunctival allografts and autografts and SLED helps in repopulating the stem cells.
So our limitation were it was a retrospective analysis with a small sample size, and several surgical steps were involved in the procedure, like removal, dissection of the fibrous tissue from the ocular surface, and placing the Gore-Tex involves amniotic membrane, and it has to be sandwiched between the two amniotic surfaces. It can't be glued to the ocular surface. That was a disadvantage. It has to be sutured with the 10-0 nylon sutures to the ocular surface, and little longer surgical time was also required, and cosmetic concern was noted in few patients. And Gore-Tex, concluding, seems to be very safe in young children. It can be cut into different shapes, and it is easily available and effective in preventing the fibrovascular regrowth. It is more or less repeatable also, and there was no sight-threatening complications noted, and in future it can act as a novel surgical option to prevent the recurrence in various ocular surface disorders. In this case, was total symblepharon was managed with placing Gore-Tex superior and inferiorly with conjunctival allografts from the cadaver as well as from the fellow eye. Thank you.
Thank you, Dr. Anita.
Thank you.
My question would be, why did you embark on this study?
Sir, because there were so many patients we had with severe grade of symblepharon, and there was a recurrence of the growth in every patient which we operated. So we thought we wanted to prevent the recurrence of this growth, fibrous growth, and most of them were young children. So, and with chemical, they come with very grade 4 alkali injuries. So we thought we'll do something for recurrence.
No, my question was a little different. My question was, we have other materials which have been well talked about in literature, silicone, etc. Why would you choose Gore-Tex, and what was the reason for doing this? Because were you looking at a cost benefit? Were you looking at a material benefit? What was the hypothesis behind this?
Yes, sir. Gore-Tex was like inert material, and it is biocompatible, sir, and it resisted infection, and the epithelialization was very good. Underlying the Gore-Tex, the epithelialization, that surface was very good, and the recurrence was very less, and fibrous tissue overgrowth over the Gore-Tex did not occur.
Did you compare it with the other materials?
That was not done, sir, maybe.
Okay.
Thank you.
Thank you.
The next paper is by Dr. Marian Pauly.
Good afternoon, everybody. My paper is on the effectiveness of triple therapy in this thyroid optic neuropathy, a retrospective study. No financial interest. So why DON is important? I got a 64-year-old male, retired driver, hyperthyroid at presentation, was a chronic smoker, status post intravenous methyl prednisolone. On examination, right eye no perception of light, left eye perception of light, fundus both eyes showed optic atrophy. He refused orbital decompression after listening to the complications and side effects, and finally he committed suicide. So as we know, this thyroid optic neuropathy is a serious complication of thyroid orbitopathy with incidence of 5 to 8.6%. Early diagnosis and management is essential to prevent blindness. Various treatment modalities has been described with a variable success rate, but no definite protocol for the management of dysthyroid optic neuropathy. So in this scenario, we did a study to determine the efficacy of combined modality treatment in the management of dysthyroid optic neuropathy. It was a retrospective study done from 2015 to 2020 in treatment-naive patients presenting with dysthyroid optic neuropathy in a tertiary care center in South India. The diagnosis of DON is based on at least one of the following clinical findings and one of the additional diagnostic examinations. One, worsening of bus-corrected visual acuity in comparison with the prior visit in referred cases. In cases where the first visit took place during a suspected DON, BCVA with the pinhole being less than or equal to 6/6 but not owing to corneal problems or any other pre-existing eye diseases, positive RAPD and or optic disc edema. With an additional diagnostic examination of visual field testing, color vision by Ishihara's chart, and orbital computer tomography. So the treatment protocol is, once diagnosed, a loading dose of intravenous methyl prednisolone 1 gram IV OD for 3 days, followed by intravenous methylprednisolone 500 mg every week for 6 pulses. After 2 weeks of starting pulse, orbital radiation was given in a dose of 20 gray in 10 fractions over a period of 2 weeks. After the fourth pulse of methylprednisolone, immunosuppressant azathioprine was added in a dose of 50 mg once daily for 3 months, followed by 25 mg once daily for 3 months. After the 6th dose of intravenous methylprednisolone, oral steroids in a dose of 30 mg per day for 1 month with monthly tapering was added. Patient was followed up every week for the 6 doses of pulse, then monthly for 4 months and then 3 monthly. At each visit, vision, color vision, intraocular pressure and fundus was evaluated. Blood parameters were also monitored for diabetes mellitus and liver function. The main outcome measures were improvement in visual acuity, color vision and improvement in visual fields. So we had 11 eyes of 9 patients aged 47 to 73 years with a mean of 57.5. Males outnumbered females in our study. The follow-up was ranging from 12 months to 50 months with an average of 26 months. All patients were hyperthyroid and color vision was abnormal in all eyes. RAPD was present in 7 eyes. 2 patients had bilateral DON, so the pupil was sluggish and RAPD could not be assessed. Coming to the pre-treatment visual acuity, 36.4% of eyes had visual acuity which is 6/60 to 6/18, whereas 3 eyes had visual acuity less than 6/60. Visual fields were done on day 4. Only 7 eyes we could do, and 4 eyes had inferior defects, but 2 had normal fields. Disc edema was present in 36.4%. Coming to the post-treatment visual acuity, 100%, almost all patients required good visual acuity, that is between 6/18 to 6/6. Only 1 patient had 6/12, that was due to the corneal dry eye. So this is a case. He is 47 years, presented in November 2017. He was hyperthyroid, left eye compressive optic neuropathy, vision 6/6, color vision 15/21 and RAPD. Fundus showed disc edema. Fields were relatively normal. He was treated with triple therapy and this is his follow-up picture. Disc edema has resolved, few coronal folds were persisting, fields retained. This is another patient, 61 years, again bilateral compressive optic neuropathy with inferior altitudinal field effect, and after triple therapy fields were improved and vision and color vision also regained. Complications, drug-related nil, 2 eyes had radiation-induced dry eye. So dysthyroid optic neuropathy, as per OPRS 2018, there is little evidence regarding the optimum management strategy. Role of steroids, it is anti-inflammatory, first-line treatment, where effects can be partial and short-lived. Response rates range from 45 to 83%. Orbital radiotherapy combined with the steroids, in one study 93.3% did not require any decompression surgery in the acute phase. Immunosuppressants as a steroid sparing drugs, I have used Azoran because it is cheap and well tolerated. Decompression, again success rate is variable and has got complications. So why combination therapy? Complete visual recovery, no recurrence, augment the effects, synergistic action, less side effects, no surgery related complications, and finally it improves the quality of life also. It's a small sample size. So to conclude, the study adds sequential combination therapy using steroids, orbital radiation and immunosuppressants can attain complete and persistent visual recovery in patients with dysthyroid optic neuropathy. It can avoid acute phase surgical decompression and related complications. Thank you.
Any relapse cases?
In the treated patients, no. In the other eye of the treated patient had compressive optic neuropathy. Other eye of the treated eye. Thank you.
Yeah, the next speaker, Dr. Manoj Kumar. Yeah.
And we have to continue with the semi-finals also after that.
Oh, really?
Yeah.
Come back.
Yes. Yeah. Okay. So what we do?
Next slide. Yeah. Good afternoon, everyone. Good afternoon, one and all. I'll be presenting on this topic. The authors of this study has no financial disclosure or conflict of interest with the presented material in this presentation. During the pandemic of COVID-19 SARS infection, India has experienced a surge of dreadful fungal infection, rhinoorbital cerebral mucormycosis. And mucor is a saprophyte of order Mucorales, and mucormycosis is an acute and often fatal opportunistic infection. The conventional management includes control of the metabolic abnormality, administration of metabolic systemic amphotericin B, and surgery that involves simple sinus clearance, radical debridement, and orbital excenteration. Orbital excenteration is a surgical removal or orbital contents, including the eyeball. Excenteration is performed as a life-saving measure for primary or secondary orbital malignancies where conservative treatment has failed or is it not feasible. So excenteration can be performed by either an eyelid sparing or eyelid sacrificing technique. Ideally, the eyelid sparing technique with suturing of the eyelids is preferred. However, most of the patients developed wound gaping. Some surgeons advocated spontaneous granulation where orbital cavity has to be lined by temporalis muscle, forehead flaps or grafts, and this offers comparable cosmetic results. However, healing by granulation takes longer time and requires intensive post-operative care. This is one of our patient who a post-operative eyelid sparing technique with complete no gaping. And the second picture shows that there's a lateral orbital wall gaping. And the third one is the post-operative patient of eyelid sacrificing technique. And the fourth image is it's a post-graft anterolateral aspect of thigh graft. Then the purpose of the study is to study the epithelialization of orbital socket and to compare the post-operative outcome in eyelid sparing and eyelid sacrificing techniques, post-exenteration in COVID-associated rhino-orbital cerebral mucormycosis at a tertiary eye care center. In the materials and methods, it's a prospective interventional study conducted at a tertiary COVID-19 hospital between May 1st, 2021 and July 30th, 2021 for a period of 3 months, where 35 patients were subjected to relevant medical history, ocular examinations, and patients with visual acuity, no perception of light, pupil dilated and fixed, severe ptosis, proptosis, with or without involvement, incomplete ophthalmoplegia, and extensive involvement of the skin over the eyelids and bilateral orbital involvement were subjected for exenteration. And patients were divided into two groups based on the surgical technique performed, namely the eyelid sparing as group 1 and eyelid sacrificing as group 2. And these patients were followed up for epithelialization of the orbital socket in eyelid sacrificing and wound healing in eyelid sparing exenteration over a period of 4 weeks. So our observations were gender distribution. Out of those 35 patients, 18 and 17 were included in eyelid sparing and eyelid sacrificing technique as group 1 and group 2. Of them, 27 were males and 8 were females respectively, with a male preponderance. Coming to the orbital socket epithelialization at 2 and 4 weeks, medial wall of the orbital socket healing at 2 weeks showed no granulation in 4 and 2 patients, granulation in 14 and 15, whereas lateral wall showed no granulation in 13 and 10, and granulation in 5 and 7 respectively in group 1 and group 2. By 4 weeks, medial wall showed granulation in all the 18 and 17 cases, and lateral wall showed no granulation in 2 and 1 cases, and granulation in 16 and 16 cases at 4 weeks respectively. Coming to the wound gaping in the at 2 and 4 weeks in the eyelid sparing technique, at 2 weeks and 4 weeks showed medially in 13 and 8, laterally in 1 and 1, and total in 3 and 8 respectively, showing the wound gaping was seen more medially, followed by total gaping. So coming to discussion, it's a study done by Honavar S.G. Rao sir at a study on enucleation and exenteration in surgical ophthalmological oncology concluded that these procedures can be life-saving and are used as a part of multimodal treatment in achieving the complete local remission. This cosmetic disfigurement caused by these radical procedures must be rehabilitated by a well-matched processes. So the core article was by Putterman AM et al. And study on orbital exenteration with spontaneous granulation. It was observed that spontaneous granulation technique provided better results when compared to the split thickness graft technique. In a study done by Rahman et al. On orbital exenteration, a 13-year Manchester experience, it was found that healing of the orbital defect is dependent on the method used for reconstruction, and they included temporal muscle transposition, midline forehead flaps, dermal grafts, split skin grafts, eyelid sparing technique, and spontaneous granulation, allowing the granulation of the defect healing by up to 2 to 3 months. Healing by secondary intention has an advantage of being an easier and a quicker procedure that allows reoccurrence to be detected early. And however, in cases where exenteration is performed for palliation of the neoplasm, a split skin graft gave rapid rehabilitation of the socket and minimized the hospital attendance, but lengthens the duration of the surgery. So this is another study, Gunlap et al. And this study also showed that there is a spontaneous granulation proved to be a simple technique and produces cosmetically better results for patients not wearing prosthesis. However, there were been limited studies elucidating the epithelialization of post-operative outcome of orbital socket post-exenteration, hence this study. And this is one of the same patients who went eyelid sparing technique with no wound gaping. This is the post-op eye patch with a spectacle mounted prosthesis. And the conclusion of my study was this comparative clinical study showing eyelid sacrificing technique with spontaneous granulation has early and better granulation tissue formation in comparison to eyelid sparing with wound gaping and a delayed granulation. And these are my reference. Thank you.
I wanted to ask, how did you randomize your patients into group 1 and group 2?
Ma'am, depending on the extent of involvement, like in the eyelid sparing technique, there was extensive involvement of the skin of the eyelids. So we have divided based on that into eyelid sparing and eyelid sacrificing technique.
Okay. Yeah. Thank you.
Thank you, ma'am. Thank you, sir.
Yeah, we now invite Dr. Akshay Nair. Is he here? Yeah, okay. She did not come in the first.
She did not come.
Okay.
Thank you. The title of my talk is No Rhino in Rhino-Orbitocerebral Mucormycosis, Atypical Cases, a Case Series. These are our financial disclosures, none of which are relevant to this presentation. We know post-COVID, mucormycosis has seen a surge that can present in multiple ways like mild, severe ptosis, orbital infarction, black eschar giving it the name black fungus, orbital infarction, and even severe proptosis causing globe rupture. Traditionally, what we know is that mucormycosis involves the nasal mucosa first, spreads into the paranasal sinuses, directly from the medial to the lateral edge spreads into the orbit, gradually creeps apically and posteriorly from the apex of the orbit and the cribriform fossa into the brain. Based on this understanding of ours, there has been a proposed staging of rhino-orbitocerebral mucormycosis, where in a stage-wise pattern, the involvement of the nasal mucosa is first stage. Second stage is paranasal sinuses, from where it spreads into the medial orbit, the nasolacrimal duct into the orbit, affects two structures, and finally to the apex and involves the CNS and the central nervous system, the cavernous sinus and the central nervous system. There have been other studies as well, again using the same principle of a graded system. So we know that it is a stepladder progression with anatomical compartments that get affected one by one. Signs and symptoms help us to localize the lesion and plan the treatment with endoscopy and imaging in all these cases. The authors of this paper have written over 8 papers on mucormycosis with the largest series of follow-up of over 6 months. In our series, we've noticed that there have been some atypical cases, which is what we aim to present today, which is non-conformant to known disease progression patterns. In a single center with 88 patients with a minimum follow-up of 3 months, we had 57 cases, of which 6, which is 11% of the cases, had normal nasal endoscopic findings in mucormycosis. There was no eschar, necrosis or ulceration. However, 2 had orbital disease, limited, 2 had extensive orbital disease, 2 had apical orbital disease, for which in all 3 underwent orbital exenteration. At last follow-up, live salvage was 100%. Let us take a few index cases. This is a 65-year-old male with dull pain over the cheek for 5 days with absolutely no other visual complaints, recovered from COVID. An ENT consult was taken, a nasal swab was done, and this is the endoscopic video. Pristine, clear, healthy nasal mucosa with not a sign of even mild congestion. MRI, the maxillary and the ethmoidal sinuses are completely full. The pterygopalatine fossa lights up and mucosal edema is observed there. Endoscopic debridement was done, which confirmed the diagnosis of mucormycosis. For the limited orbital involvement, retrobulbar amphotericin B injections were given. Systemic treatment was done for mucormycosis, and at 3 weeks there was no recurrence. Patient was discharged on oral posaconazole after systemic ampho injection. Second case is a 53-year-old male, again with a history of COVID 15 days ago. Rapid onset of loss of vision, ptosis and pain. Again, nasal mucosa. This is an iatrogenic bleed caused by the endoscope. No ulceration, no eschar. However, the disease shows complete orbital involvement with loss of contrast and perineuritis. The sinuses are full. Again, you can see the contrast enhancement being taken up in the nasal mucosa, suggesting that the mucosa was still healthy. An exentration was done and the patient was discharged after complete recovery. This is case 3, a patient with mild ptosis and nothing else, apical disease involving the cavernous sinus but pristine nasal mucosa. Which then brings us to this proposed staging that was seen. First case has no nasal mucosal involvement, so has skipped stage 1 and directly jumped to stage 3 without nasolacrimal duct involvement. Case 2 has no stage 1 involvement, has one sinus of stage 2, which is stage 2A, 2B, and directly jumps to stage 3B, not in a sequential form. This is the third case where again the nasal mucosa was normal with direct jump from stage 2A to stage 3C and to stage 4A. So, coming back to this slide that we saw earlier, our series shows that this step ladder progression is no longer applicable. Anatomical compartments affected one by one is not the case. Signs and symptoms cannot help us localize the lesion. It is endoscopy and imaging alone that will help us decide. But why do we see these lesions that don't affect the nose and involve the sinuses? The important area that we forget is the infratemporal and the pterygopalatine fossas, which have direct access to the skull base, the orbit, and the apex of the orbit. Perineural invasion is the other mechanism that we tend to overlook. In addition, we are talking about severely decreased host immunity along with compromised local mucosal immunity, which allows the organism to invade. 5 out of 6 patients had edema and enhancement around the pterygopalatine fossa, which is a high risk of cavernous involvement. We have proposed a radiological based classification which has been published in Orbit. To summarize, stepwise progression is not routinely seen in mucormycosis. Aggressive disease, especially in rapid progressive form, is seen following COVID. Anatomical assumptions no longer hold true. It is radiology, and radiology, most importantly, that helps in staging and classifying disease that can help us treat. And it has to be done in consensus with our ENT and neurosurgery colleagues.
Okay.
So you do carry on your surgery up to the pterygopalatine fossa. It has to be go up to that
ENT
layer.
surgeon,
Then only you can
yes,
remove everything.
because that has even a lot of patients that we've also seen after debridement of the sinuses for a long time have recurrent disease that we see on MRI. And it is the ENT surgeon who suggested that we need to clear this reservoir of pterygopalatine
But the anterior
fossa.
part was okay. Do you remove the anterior part also?
No. So
Okay.
if
Only go
imaging
back.
there is no mucosal edema or involvement of the pterygopalatine fossa, then they
Okay.
leave it. Only in cases where they see it, even though the mucosa may be healthy, if on MRI it is it lights up, as in there is a contrast alteration, then the ENT prefers to be aggressive, especially in younger patients.
Did the ophthalmic management change depending upon the mucosa involvement?
So if we look at the classification system that has been proposed, it says that if the nasal mucosa is involved, the treatment is to observe or give systemic amphotericin B. No surgical involvement, no retrobulbar amphotericin B. Retrobulbar amphotericin B is indicated in stage 3B as per the proposed classification. So here we are seeing patients who had presentation would have been classified as disease stage 1 and been let go. So misstaging and understaging may occur if we don't treat every patient as an advanced disease, do an endoscopy, do an MRI and do a scraping on suspicion of mucormycosis.
Thank you.
Thank you.
Thank you. So we come to the end of this session, and the second